Both palliative and hospice care they're not new. I mean, really, I guess prior to modern times, all we had was a form of palliative and hospice care. And the characteristic of it was that it was largely spiritual care. Well, today, both palliative and hospice care have a clinical and a spiritual dimension to them. You know, it doesn't mean that we're going to kill a patient. It simply means that we're changing the kind of care that we deliver in order to help the patient die comfortably or to manage chronic illness. And I think today there's a lack of awareness about both of those, although they're becoming more accepted. But we need to remember that they're different. They have some things in common. Palliative care is geared toward managing the symptoms of chronic illness, you know, diseases that we can't cure, but we can make it as pleasant or at least as bearable as possible, whereas hospice care is geared just toward patients who are dying. And they are both marvelous opportunities for us to reintegrate clinical and spiritual care and to provide non-aggressive care for patients who don't need that. You know, what they need is another kind of care. We're not giving up on them. We're just saying, all right, you have this set of conditions or you're in the process of dying. We're going to change the way that we treat you. Because I think until recently we kind of had one model fits all. You know, everybody gets aggressive medical care, often types that they don't even want or need, at great expense and inconvenience to them. Both palliative care and hospice care are attempts to avoid that and to deliver care that's appropriate to those patients and their circumstances. In medicine, you know, there's this thing which theologians refer to as the principle of double effect. And it's something that we invoke in almost any medical procedure that causes pain or discomfort. You know, this is going to hurt, but then you'll be better. And the same thing is true in end-of-life care. It simply means that there are some procedures or treatments that we use that have the purpose of healing, but they might also cause pain or suffering or even hasten death. But we can do them as long as our intent is not directly killing the patient. You know, so for example, with a patient who's dealing with end of life situation, we increase medication, pain-killing medication. The purpose of it is to reduce pain, and we know that it might also suppress respiration and cause death, but it's okay. You know, as long as our primary purpose is to alleviate pain and our intention is not to kill the patient. And you might say, well, it's a fine line. Yeah, it is a fine line, but we can draw it. There is a way in which we can be clear about what our intention is. I know a woman whose husband had a chronic progressive disease, and the doctor said, you know, we really can't do much for him. He was in the hospital again for the umpteenth time. So she said, I'd like to take him home and put him in home hospice so we can spend, you know, our time together. And the doctor said, why would you give up on him? And she said, you just told me there's nothing more you can do. And this guy at a major teaching hospital in the US had never referred a patient to hospice. And I think that's still a problem. I think many physicians either don't know how to raise the question or they don't have the spiritual strength maybe to raise it.